Okay. I'm thrilled that there's a lot of redundancy with what I'm about to speak about. So I'm just going to talk a little bit about getting started building a heterotaxy program. After the last day and a half, this should be sort of a duh moment, but I'm going to explain the rationale for a heterotaxy program and just share a few tips to start building a local heterotaxy program. By way of background, we see a tremendous number of patients with heterotaxy at Boston Children's. This gives you just a sense through 2023. These are unique patients that have care at Boston Children's every year. It's not new patients every year, so there are certainly some repeats. But you can see the number that we typically see is around 280, 290. Also of note from local New England, but also some from across the country and throughout the world. And before we had our program, this was the way that heterotaxy care seemed to me. It's everything's cardiac forward, but what about all these different things that we might not be paying close attention to? And of course, as we've seen over the last day and a half or so, there are many non-cardiac elements, and I realized that I was not equipped to care for biliary atresia, malrotation, duodenal atresia, ciliary dyskinesia, and what have you. Of course, we've heard about the non-cardiac manifestations of heterotaxy just as much as we've heard of the cardiac manifestations in the last day and a half, which is terrific. So our goal, our mission statement, and I do think a mission statement has real value, is that we recognize that heterotaxy is complex, multifaceted, and affects multiple organ systems throughout the body. And our goal is to provide comprehensive multidisciplinary care to infants and children, I should really add adults with heterotaxy, including screening, management, intervention, and follow-up, and that is in order to optimize outcomes. So we talk about building a team, and I'm just going to say this. It's not as hard as you think. Step one is to just identify institutional champions. It does not need to be a group of 30 people. Just identify a core that is willing to take on the care of patients with heterotaxy, be institutional champions, and meet on a regular basis to think about how we're providing care. I think it is helpful in terms of an initial composition to think about your cardiology providers. Dr. DeWitt, who you heard from yesterday from electrophysiology, has been exceptionally helpful. Colleagues in intensive care and advanced cardiac therapies are very valuable, and of course, someone with surgical expertise in complex anatomy is critical. As far as the immune piece, we're fortunate that we have Dr. McDonald, an immunologist, but really this can be an immunologist, a hematologist, an infectious disease specialist, anyone who's willing to take on that aspect of the care. Certainly pulmonary, as we have heard, and genetics, and then also gastroenterology and general surgery. And I will say we do have a hepatologist who has been lending his expertise to our team, and as we learn more about biliary atresia and portosystemic shunts, which you're going to hear more about later today, having a hepatologist be involved is super helpful. I'm going to take a little bit of a different angle on the identifying patients with heterotaxy. Up here on the stage with me is Caitlin O'Connell, who is our just superb nurse practitioner for the program. She's not just the glue, she's the super glue of the program. But as we have learned in the last 3 years since we've been doing this, identifying patients with heterotaxy, I think, sometimes can be trickier than it seems. Certainly we have those that are sort of following into the polysplenia left isomerism or asplenia right isomerism phenotype. But we've really become the situs team as well. So anytime there's situs inversus totalis identified prenatally, we become involved and directing those patients and families to the right providers has been extraordinarily helpful. We also get questions from all over the hospital, does this patient have heterotaxy? One of my favorite anecdotes was one of the surgeons who was doing a relatively straightforward ASD repair. He calls me and he says, I think those two appendages look the same. I think you should see this patient. I was like, wow, okay. So helping to parse out who and who doesn't have heterotaxy can be very helpful. Of course, as we learned, that can be very tricky to do, and we're still learning how to do that, but we do our best, and I think it's an important service. In general terms, though, we do use the 8 criteria that have been published in a variety of settings, using 3 out of 8 criteria from the diagnostic categories. So how do our operations work? So here's my advice, is to start small and grow from there. When we started, we were a loosely organized group. This was in the, let's say, bad old days before Caitlin came along to help us out. But we started with neonates in our cardiac intensive care unit. That was a very discrete group in a specific location, and it really helped us to sort of get our sea legs and get our bearings in terms of how we would interact with a group, what was an appropriate workup, and sort of take things from there. We have grown, of course, to see any inpatient that requires a consultation, patients that are regional coming for surgery, other procedures. We have gravitated to general outpatient consultations, and something that we're both very proud of is prenatal consultations, which you'll hear about in a moment. It is important to clarify your process, how you're going to work together. Will this be individual consultations, or will an advanced practice provider be doing a summary note, which is what we have gravitated to? Will you do inpatient and or outpatient consultations? What is the cadence of visits that you've heard about from Dr. Spurgeon? And document is extremely valuable, and I can tell you that from the hospital administration perspective, they're going to be interested in documentation and billing and demonstrating the value of the program. And of course, meeting regularly is very valuable. Seeking support from your institution is very helpful, and other funding opportunities. I've said multiple times about a nurse practitioner or other advanced practice provider. I cannot underscore enough what Dr. Spurgeon just said about engaging trainees. I have to say one of the most gratifying things is seeing people with whom I have worked, who I have trained, who I've learned from, go on to really engage in this heterotaxy community. I'm going to call out Nicole Saneri, who's one of our second-year fellows, who actually walked into fellowship wanting to become very involved with heterotaxy. So she's sitting there about 2/3 of the way back. You can meet her later. And then, of course, collaborate with Heterotaxy Connection and HRC3. This gives you a little bit of an overview of the different types of activity that we do. And I'm including it here because it's a real variety. I think there's value on the outpatient side and the inpatient side. We provide remote second opinions, and as I mentioned before, we started our prenatal consults as well that you'll hear about in a moment. You'll see in purple, and I'll just point that one out, and this is as of 2020, I can't remember, January of this year. More and more patients are walking into Boston Children's Hospital because of the heterotaxy program. And again, we're getting into that question of demonstrating value and really showing hospital leadership how important and valuable a program like this can be. I'm almost done, I promise. Who wants to advance? Our goal overall, wherever you come from, you come through the program, you get heterotaxy education and resources, multidisciplinary care, or care guidance. Educational material is super valuable. Caitlin has worked tirelessly in putting together educational material for a number of different disciplines, which I think is very, very helpful for families because the amount of stuff that's out there is a little bit limited. So this is our team. I would just call out a couple of people. Dr. Hoganson, who co-leads the team with me, Caitlin, who also co-leads the team, and getting back to that trainee idea, so no longer a trainee, Dr. Ben Zielanka, who just came on faculty, will has assumed a formal role within the program, which is absolutely terrific. So we thankfully have gone from something like this to something like this, and our goal is to have patients like my buddy Xander here, who is absolutely thriving with heterotaxy. So